Good morning all. I am Dr. Shanthakumari, Assistant Professor from the Department of Public Health Dentistry. Today we will discuss about the palliative care in dentistry. Before knowing about the palliative care in dentistry, it is necessary to understand the basic concept of palliative care. These are the topics in this session which I am going to discuss today pertaining to the palliative care. Palliative care is a specialized medical care for the people with serious illness. It is explicitly recognized under the human right to health. It refers to enhancing the physical, psychological and social well-being of patient and their family members. In palliative care, whatever the prognosis is, it is focused on providing relief from the symptoms of a serious illness, which is considered to be the utmost goal of palliative care. Palliative care is provided by a team of doctors, nurses and other specialists who work together to provide an extra layer of support. Palliative care is given at any age and any stage of serious illness. Sometimes it also provides curative treatment. Thus, the goal of palliative care is achievement to the best quality of life to the patient and to their family members. Let us see the epidemiology of palliative care. A report says each year 40 million people are in need of palliative care, among which 78% of them live in low and middle income countries. Currently, only 14% of people who need the palliative care are receiving it. So, this data shows the extent of palliative need to the patient. Let us see the key features of palliative care. They are goals and plans of palliative care that are based on patient and not on the condition of the disease. It is not related to prolonging the life, but it is related to decrease the suffering from the disease. In planning the palliative care, not only the patient, the caregivers are also involved in it. Palliative care team is strictly a multidisciplinary team called palliative care team, which should be appropriate for all patients. It is not just only for the terminally ill patient. Palliative care neither hastens nor postpones the death, but it improves the quality of life. Coming to the history, actually the idea behind this palliative care was originated during the 19th century. The first hospice palliative care team was established in Royal Victoria Hospital, Montreal, by the person called Balfour Mount in 1976, which is followed by many palliative care programs. The history begins with Dame Cicely Saunders, who started St. Christopher's Hospice in 1967. The philosophy of this hospice is palliation should be a holistic care emphasized on emotional, social and spiritual needs. In 2014, first global resolution on palliative care was called upon by WHO Assembly to improve the access to palliative care as a core component of primary health care. And also it is focused on community-based care and the home-based care. Let us see the history of palliative care in Indian perspectives. In 1980s, only few pain clinics were existed. In 1986, modern palliative care was introduced in Bombay. After that, in 1993, Pain and Palliative Care Society was started in Kerala. The next year, 1994, Indian Association of Palliative Care was launched. After a short break in 2001, again the neighborhood network in palliative care was started in Kerala. In 2003, a registered national charitable trust was formed named as Pallium India. In 2018, a palliative care policy was implemented by Kerala State. In 2010, Medical Council of India recognized palliative care as a specialty branch. After that, in 2013, National Program for Palliative Care was launched by the Government of India. Finally, in 2016, Kerala University of Health Sciences included palliative care into BDS curriculum under the subject of Public Health Dentistry. Next, we'll see the definition of palliative care. This is the definition given by the WHO, which aims at patient's quality of life in spite of discomfort in physical and mental condition. Next, we will see what is hospice and principles of palliative care. Hospice is the place where the caregiver specifically cares the patient with survival period which is typically less than 6 months. As we discussed previously, the principles or components of palliative care are keeping ongoing communication with the patients and their families, providing them care for management for pain and symptoms which are associated with their existing disease. Other components includes monitoring medication, assisting patient in their daily living, for example, bathing, dressing, etc. Also, it addresses the psychosocial and spiritual aspects of the patient care, and giving them counseling for their grief and bereavement are considered to be the principles of palliative care. Thus, the overall motto of palliative care is offering a support system to the ill patients to live actively as possible until death. Next, we will move on to the quality of life. What is quality of life? It is the central concept of palliative care in healthcare. It also defines as subjective evaluation of life as good or satisfactory all. Now, we will see what is health-related quality of life. It is not the absence of disease, but how the life events influence the quality and quantity of life. However, quality of life is not static. It will change as the disease progresses. Therefore, quality of life should be assessed regularly, either at every clinical visit or consistently over time to detect patients' improvement, stability or deterioration with palliative intervention, for which health-related quality of life is measured through reliable and valuable questionnaires. The palliative caregivers will engage the patient in conversation around the areas in their life which are deeply affected by serious illness. Now we will see how the health-related quality of life questionnaires are designed and measured. Health-related quality of life questionnaires are based on three aspects. One is generic, next is disease-specific, and third is domain-specific. Generic tools are not specific to any population or diseases. They are applicable to people with more than one diseases, and it is used to make comparisons across population and diseases. Next is disease-specific, which is developed for specific group of patients who have specific diseases. For example, cancer group of patients. Domain-specific instruments or tools are used to assess specific domains within the overall concept of health-related quality of life, such as fatigue, pain, or psychological distress. However, quality of life use combination of all these three measures. We usually come across the word concept of good health, but what is this concept of good death? Patients who are in terminal phase of diseases like head and neck cancer patients, death may be inevitable. In this condition, palliative care promotes and constructs for good death, which helps the patient and the families to be favored at the end of life. The important components of good death are keeping the patient free of pain, arranging family members to be with them, making the patient to accept the death psychologically, and to keep them at peace are considered to be the concept of good death. Now coming to the role of teamwork, which is very essential in palliative care as they work closely together. In palliative care, the multi-professional team may be interdisciplinary and multidisciplinary. Usually, multi-professional teams are employed in areas where patients who have extensive and complex needs. In multidisciplinary team, members provide their vital information towards the decision making. Usually, only one person in each team, that could be a physician or nurse. Sometimes in common decision making process which demands an interdisciplinary approach where members share common team goals. They work interdependently in planning, decision making, implementation and evaluation of team related tasks. So this is all what we need to know about the teamwork in palliative care. Thus, if we see the objectives of interdisciplinary team, which includes accurate and speedy assessment of need of the patient, efficient communication with patient and their family, and the third one is auditing the team's activity and outcomes are considered to be the objectives of interdisciplinary team, which are very essential in the palliative care teamwork. Now let us see how these team members have to be chosen for giving a palliative care. Firstly, team members are divided into three domains. They are core team, extended team and family members. The core team includes physician or consultant and specialist nurses who work on full-time or part-time who will provide palliative care. Next, the extended team, which is ideally designed to address all the needs of patient and their family members. In our field of dentistry, dentist, dental hygienist are important members of extended palliative care team who will provide even a domiciliary dentistry. Finally, the family members who can be included in the team who will have the overall role on patient care, including formulating plans and treatment which is needed for a patient. Moving on to the role of family and caregiver in palliative care, we need to understand the impact of patient's illness on family and caregivers. So they must also be considered in palliative care. If we see the task of caregivers, which include dispensing medications, assistance during nausea, vomiting, pain relief, washing and meal preparation, laundry, answering phone calls, etc., which in turn will really give them a high level of depression and anxiety that may affect their mental health, like inadequacy, guilt, anxiety, fear and grief. So a caregiver need to adopt certain coping strategies to overcome this kind of conditions, like understanding the information about the diagnosis and prognosis of the condition, getting assistance for his own physical and mental symptoms, managing personal care such as sleep disturbance, weight loss, maintaining family stability and even altered family roles and choices, etc. So thus the effective symptom control in palliative care is enhanced by the family as a caregiver. Next we will see the role of communication in palliative care. Basically, palliative care depends on good communication. Good communication requires techniques to understand the emotional status of a patient. Quality of good communication is ask before telling, which means often people carry misconceptions or incomplete information on their own illness through a social media, friends, family, folklores, etc. Thus, we have to understand their illness before educating them. So, we have to realize that palliative care will be facilitated by a honest, open and empathetic communication. Now, we will discuss how to deliver a bad news to the patient who are in terminal stage of a diseases like advanced cancer, heart diseases, etc. There are certain models which helps us to deliver good or bad news to the patient and their families. One such model is Spikes and Nurse model. Spikes is an acronym used for delivering distressing information in an organized manner to patients and their family members. It provides a stepwise framework for difficult discussions such as when cancer recurs or when palliative or hospice care is indicated. It helps us to ease the distress felt by the patient who is receiving the bad news and to the person who is breaking the bad news. This model serves an excellent framework for most difficult conversation. In Spike's model, each letter in the acronym denotes one component of this approach. The first letter is S. It stands for sitting, which means difficult conversation has to be conveyed in private room with keeping the phones in silence, taking adequate time, making key participants available at the time of delivering bad news, etc. The next letter P denotes perception, which means asking the patient or family members like, tell me your understanding about this situation. So we can throw such kind of questions to them. And the next letter I denotes the invitation. This means inviting the patient or family members, asking questions like, is it okay if we talk further about this? So the next letter K stands for knowledge. While giving the bad, we have to note a thing while giving the bad news, give it in a short, clear, digestible and in non-technical language, because after delivering the bad news, we have to be quiet also and wait until they speak again, thus allowing them to take the message slowly. The next letter in the acronym E stands for empathy. This component uses nurse model or similar strategy to demonstrate the empathy towards the patient and the patient family members. The last letter S stands for summary or strategy, which means summing up the information that would be helpful for them. Something like talking about the next steps like recommending hospice care, etc. So this is how the bad news has to be delivered to the patient and to the family members in a systematic way. The other method of delivering bad news is using the nurse model for demonstrating empathy. NURSE, N-U-R-S-E, is a valuable tool for demonstrating empathy. Here the acronym N stands for naming or mirroring the emotion. For delivering empathy, we could use the empathetic statements like, I imagine this must be upsetting. Like this, the next acronym U also stands for demonstrating the empathy. That is, U stands for understanding their emotion. For example, by saying, I expect most people would feel the same situation like this, is something understanding their pain by asking all these kind of questions. Then the letter R stands for respecting the patient. Respecting the patient regarding how well they have handled such a tough situation. The next letter S, which stands for support, that indicates supporting the patient using powerful words like I will be with you to help through this. Finally, the E means exploring the emotion further, like asking more questions, the situation, how they feel and what this means to them are a kind of questions that will help us to deliver the news in a systematic way so that they can digest the shocking news slowly. Next, we will discuss about the rehabilitation in palliative care. According to WHO, palliative rehabilitation aims at minimizing the effects of advancing disease, supporting people to act independently, to cope with the distress associated with the disease and to educate them regarding the progress of disease, and also makes the patient to accept it psychologically. Next, we will see the core interventions of palliative care rehabilitation. The aim of palliative care is to improve the quality of life for people living with life-limiting illness, which can be achieved by exercise and activity, participation in daily life activities, non-pharmacological symptom management. Here, why do we need to make palliative care patient to exercise and to make them involved in daily activities? Because to maintain their physical functioning and independence of work. The exercise and activities is recommended based on their condition of the disease. It is not recommended for all the patients, it is purely based on their condition of the disease. Next is making them to participate in their daily life activities, which is a core element of palliative care to maintain their normalcy of life. For example, bathing, dressing, etc. The other rehabilitation intervention is non-pharmacological symptom management, which means including the physiotherapist and occupational therapist to make the patient to master over a symptom or control over their own symptoms associated with the diseases. Thus, the rehabilitation in palliative care is an important approach in transforming patients' quality of life. That's all about the basic concept of palliative care in this session. Let's see the role of dentist in palliative care in the next session. As we all know, the role of dentist in palliative care is an essential one and utmost need too, which will be discussed in the second part of this discussion as role of dentistry in palliative care. Thank you for watching this session.